Dr. John Bennett from sunny Miami. This is another in a conference for neurotrauma. We have the pleasure of having Les Garson, an anesthesiologist from University of California at Irvine, who's actually done a hangout with us before when we were exploring the technology of Google Glass. And Les has been kind enough to come back again for anesthesia and neurotrauma. Good day, Les.
Hi, John. Thanks for having me.
Yeah, thanks for coming, and thank you for being open for the idea on probably your day off. So I'll let you start off, and it's all yours.
Okay, thank you. So good afternoon, everyone. My name is Dr. Les Garson. I'm an anesthesiologist, associate professor at the University of California of Irvine. And I'm going to spend the next 15 minutes or so talking about anesthesia and neurotrauma, which actually is for anyone who works in a level 1 or even a level 2 trauma center, that's a pretty common thing that we all deal with. So I'll have some slides here, and I'll be dropping them down and pulling them up intermittently as we talk. So first of all, as you can see, what we have here are from the Brain Trauma Foundation recommendations that are based on the class of evidence. So many of the things I'll be talking about will note whether they're level 1, which is a high degree of clinical certainty, level 2, moderate degree of clinical certainty, or level 3, a degree of clinical certainty that has not been established. So this is a typical patient that, like I said, if you work in a level 1 trauma center, and actually if you work anywhere, even in a community hospital, it's not uncommon to see a patient like this. This case is a relatively young man involved in a motorcycle accident, comes to your emergency room, and you get a phone call from the neurosurgeon that he needs to do an emergency craniotomy. The patient's had multiple trauma, lacerations to his head, previously a healthy young man, no previous surgeries, is on no medications, has a 10-year pack history of smoking, drinks alcohol regularly. The patient comes up from the ER. He's a thin male, lethargic, somewhat combative, actively vomiting. Weight is about 75 kilograms. Note the heart rate is 52. Blood pressure is quite high at 196 over 102. Respiratory rate is 20. Airway exam shows receding mandible. Lungs are clear. He has a sinus bradycardia. His neuro exam, the patient does not open his eyes to noise or pain. His pupils are unequal, though reactive. He can withdraw his right arm and leg to painful stimuli, though he does not move his left arm or leg. Cervical fractures have been ruled out, and you know from a companion that arrived with him that he had a fair amount of food and beverages 1 hour prior to his injury. So, what are you, as the anesthesiologist, going to do now? What are your responsibilities? Here's the CT scan. Obviously, you don't need to be a neurosurgeon to note that there's an acute subdural expansion of fluid, most likely blood, what is known as a subdural hematoma. So, in a sentence, the responsibility of the anesthesiologist is to maintain good cerebral perfusion with well-oxygenated blood. And if you do those two things, you are fulfilling your role as providing good anesthetic care to a patient with neurotrauma. The challenge, of course, is 1, maintaining good cerebral perfusion, and 2, ensuring that the brain is receiving well-oxygenated blood. And we'll talk about some of the principles underlying those two goals, and then briefly what the anesthesiologist does to ensure that. So first of all, the patient most likely has elevated intracranial pressure. What are symptoms of that? Well, as many of us are probably aware, headache, nausea, vomiting, pupillary changes, depressed levels of consciousness, and probably what we've all learned in medical school at one point, what's known as Cushing's triad, which is irregular breathing or slow breathing, hypertension, and bradycardia. And these three things are all related to the elevated intracranial pressure inside the cranium. So, what is the goal and treatment for increased intracranial pressure? Well, first of all, how do we define elevated intracranial pressure? That's defined as anything over 15 millimeters of mercury. Symptoms typically occur at 18 to 25. Herniation of brain, and we'll have a couple of slides that show areas of the brain that do herniate in a little bit. But herniation can occur at 20 to 25 millimeters of elevated ICP. And the symptoms that develop are very dependent on the cerebral blood flow and the cerebral perfusion pressure that occurs. And basically the cerebral perfusion pressure, in essence, is partially determined by what that ICP is. And we'll get to that in a second. So current data support that 20 to 25 millimeters of mercury is the upper threshold above which treatment to lower intracranial pressure should be initiated. There's also a threshold for that treatment for cerebral perfusion pressure. We want the lower cerebral perfusion pressure limit to be 50 to 60 millimeters of mercury. Well, what is the cerebral perfusion pressure? How is that determined? That's actually a pretty straightforward equation of mean arterial pressure taking away the intracranial pressure, or if that's not readily available, which it may not be, the central venous pressure, the CVP. And many times these patients may have a central venous line in place. So that CVP can, in fact, act as a surrogate for your ICP and help you to give you a rough estimate of what the cerebral perfusion pressure is. So if a patient's mean arterial pressure is 70 and their CVP is 15, that would give them a cerebral perfusion pressure of approximately 55. So a CPP, cerebral perfusion pressure of 50 millimeters of mercury, is considered the ischemic threshold for most patients, and we try to avoid lower levels. So a CPP of less than 50 should be avoided. And this is why cerebral perfusion pressure is so important, because this takes us back to the what is a very well-known relationship between mean arterial pressure or cerebral perfusion pressure and cerebral blood flow. And it is cerebral blood flow which is really what we're trying to maintain by manipulating our cerebral perfusion pressure. And as you can see, between a cerebral perfusion pressure of 50 and 150, our cerebral blood flow stays the same. Below a cerebral perfusion pressure of 50, from here down, you see your cerebral blood flow drops off. Above 150, as your cerebral perfusion pressure goes up, your cerebral blood flow goes up. But between 50 and 150, because of autoregulation, which is the ability of the brain to autoregulate the cerebral blood flow by either vasodilating or vasoconstricting blood vessels within the brain can maintain a very stable cerebral blood flow. And that's why this blood pressure of 50 to 150 is very important. There is an upper limit though, the upper limit being approximately 70. We really don't want to get a cerebral perfusion pressure too much above that, because it's been shown in multiple studies that aggressive attempts to maintain that CPP above 70 with fluids or vasopressors should be avoided because of the higher risk to develop ARDS, acute respiratory distress syndrome. So very tight control of mean arterial pressure is important because, as you can see, that is one of the primary, if not the primary, determinant of your cerebral perfusion pressure. And here's just a quick diagram to show you what happens to the brain with different amounts of cerebral blood flow, regional cerebral blood flow. As you can see, we want to maintain that 50 cc's per 100 milligrams per minute as our optimal level of cerebral blood flow. And that, remember, is at a cerebral perfusion pressure between 50 and 150. Once you get to approximately 18 to 20 of cerebral blood flow, you're at an area of critical regional cerebral blood flow. Once you get below that, you see you develop isoelectric EEG tracings, and at 10 cc's per 100 milligrams per minute of cerebral blood flow, you are actually at the level of metabolic failure. So we've talked about cerebral perfusion pressure in relationship to mean arterial pressure. We've talked about intracerebral pressure and the impact of that on your cerebral perfusion pressure. Now going back a little bit, that's looking at some basic physiology. Let's get to something a little bit more clinical, our Glasgow Coma Scale. As a reminder, the three determinants to come up with that number are eye opening, motor response, and verbal response. And in this particular patient that we described at the beginning of this presentation, that patient's Glasgow Coma Scale was approximately 7. Why? He did not open his eyes to even a sternal rub or supraorbital pressure. His motor response was withdrawal, and his verbal response, he was moaning and groaning, and that gives us a cumulative score of 7. Why is that important? Because the Glasgow Coma Scale is very helpful to summarize the clinical signs in patients with increased ICP, and there's a direct correlation between your Glasgow Coma Scale and the severity of traumatic brain injury. A severe traumatic brain injury typically has a GCS of less than 8. A GCS of 9 to 12 is moderate, and 13 to 15 is minor. And of course, the more severe the traumatic brain injury, there's a correlation with recovery and how the patient will do, and basically morbidity and mortality. So the worse your GCS, the worse your traumatic brain injury, and that's basically indicative of more severity of intracranial injury. This is a quick slide to show typical sites of where herniation may occur. Number 1 is your cingulate herniation. 2 is tentorial herniation. You can have central herniation from the brain down to the cerebellum area. And of course, there's also tonsillar herniation where parts of your cerebellum may actually herniate down to your spinal cord area. We can get into specific symptoms for each of these areas of herniation, but suffice to say, symptoms are typically eye abnormalities like dysconjugate gaze or unequal pupils, autonomic dysfunction, which would be very labile, blood pressures, and certainly hypertension, motor dysfunction, and of course things like nausea, vomiting, and changes in level of consciousness. So back to things we can do to mitigate these increases in intracranial pressure. Of course, we want to keep that mean arterial pressure up, as we talked about, because that is what our cerebral perfusion pressure is dependent upon. But also, if there are ways to mitigate elevated levels of intracranial pressure. And one of those is by understanding the relationship between a PaCO2, your arterial level of carbon dioxide, and cerebral blood flow. And as you can see from this slide, PCO2 is this graph here. And as you can see, there's virtually a linear relationship between the level of CO2 in your blood and cerebral blood flow. So the higher your PaCO2 goes, the more your cerebral blood flow is going to go. And as you know, there are 3 compartments in the cranium: brain, blood, and CSF. So now if you have an intracranial mass because of bleeding pressing within the cranium, there's no room. If you increase your cerebral blood flow by vasodilating the vessels because of elevated CO2, you're going to increase your ICP. So control of your PaCO2 is very important, and the way we can control that is by the way we ventilate a patient. So maintaining normal PaCO2s is very important so you don't have elevated cerebral blood flow, and we'll discuss briefly in a moment the use of hyperventilation to cause cerebral blood vessel vasoconstriction and therefore decrease cerebral blood flow and therefore help to decrease intracranial pressure. But we'll talk about that in a moment in more detail, because obviously you want to maintain cerebral blood flow as well. So that is a balance. But to get to this slide, blood pressure, oxygenation, we want to avoid both hypotension and hypoxia. Hypotension, we want to avoid a systolic blood pressure below 90. Why? Once again, recalling our relationship between cerebral perfusion pressure and mean arterial pressure and ICP, needing to maintain good mean arterial pressures so that our cerebral perfusion pressure is appropriate. And as you recall, we do not want to allow that to fall below 50. So hypotension is to be avoided, and hypoxia is to be avoided because we want to maintain good blood oxygenation so that the blood that does get to the brain is well oxygenated. So hypoxia is to be avoided by all means as well. And just a reminder about the relationship between hypotension, between blood pressure and ICP. If you have a choice between hypotension and between managing blood pressure and managing ICP, from this slide you can see maintaining adequate mean arterial pressures is even more important than doing anything to decrease your ICP, because cerebral blood flow is much more affected by a decrease in arterial blood pressure than by an increase in ICP. So for the same cerebral perfusion pressure of 40 millimeters of mercury, an increase in the ICP leads to a cerebral blood flow 90% of baseline. In other words, a decrease of approximately 10%, whereas hypotension can decrease cerebral blood flow to 60% of its baseline. So when balancing your management of the patient in the operating room, mean arterial pressure trumps doing anything for ICP. We always need to maintain good mean arterial pressures. To briefly talk about IV fluids, our first choice in the operating room is normal saline or balanced electrolyte solutions like Plasma-Lyte. As you can see, the milliosmoles of both of these solutions are very, very close to the normal milliosmoles of our own blood. We want to avoid hypotonic solutions, which can increase ICP by increasing cerebral edema. So things like half normal saline, we want to avoid. We want to avoid glucose-containing solutions. High glucoses are associated with bad outcomes. So anything that has D5 in it, we avoid in the operating room. D5 normal saline, D5 half normal saline. We avoid all glucose-containing solutions. And we also try to avoid lactated ringers. As you can see, it definitely has a lower milliosmoles per liter, so it is hypotonic. And again, that can cause an increase in cerebral edema. Studies have shown in the trauma literature that patients with known or even suspected traumatic brain injury should not have albumin used for fluid resuscitation. So in our trauma bay, we pretty much avoid albumin under most circumstances, because even if the patient does not have a known traumatic brain injury, we assume they may have until proven otherwise, so we avoid albumin. And Hespan, hydroxyethyl starch, is still avoided for its potential for renal injury. A quick note about hyperventilation. Hyperventilation can be used to decrease your arterial CO2, and this, as in a few slides earlier, we noted there's a direct relationship between CO2 and cerebral blood flow. So as a way to transient decrease cerebral blood flow, we can hyperventilate and get that PaCO2 down. However, just note, this should be used only as a temporary measure to avoid herniation, because there is definitely a rebound effect where once your hyperventilation is stopped and you allow for normal carbia, normal PaCO2 levels of 35 to 40, there is a rebound effect of cerebral blood flow, not only going back up, but actually increasing above baseline, which can then cause a rebound of elevated intracranial pressure. So when we do use this in the operating room, it's typically for a brief period of time if the surgeon notes that the brain is tight and it appears just from clinical observation that the ICP is up, we'll for 15 to 30 minutes hyperventilate the patient to see if we can decrease the ICP and help the surgeon have better access intraoperatively. So in summary, we want to avoid secondary injuries. We want to recognize the signs and symptoms of increased ICP and possible brain herniation. Be aware of the Glasgow Coma Scale. It's useful in grading the severity of traumatic brain injury. We want to maintain normal tension, normal volemia, avoiding hypoosmotic solutions, good oxygenation, avoid hypercarbia, but only hyperventilate as a temporary measure. And just keep in mind that hypotension and hypoxemia are associated with worse outcomes. So the goals of anesthesia are optimization of cerebral perfusion pressure and the prevention of intracranial hypertension, adequate anesthesia and analgesia, and prevention of secondary insults by maintaining adequate oxygenation, normal capia, avoiding hypoglycemia and hyperthermia. So a good anesthetic is smooth induction with rapid control of the airway, keeping in mind possible cervical instability, as patients who have traumatic brain injury often can have neck injuries as well. Our next thing is to obtain and maintain good IV access, maintenance of stable blood pressures at induction, during the procedure, and of course at the end of the case, and temperature maintenance of normal thermia, avoiding hyperthermia and significant hypothermia as well. Thank you, and if there are any questions, feel free to contact me at any time.
Very good, Les. Thank you very much for a very clear and excellent presentation. I just have a couple of general questions.
Sure.
Particularly from an ER point of view. I guess at Irvine, you're probably the anesthesiologist right there when they have trauma coming in, or is there a delay before you guys get there?
No, that's a good question. Oftentimes not. Sometimes if there's enough of a heads up, in other words, enough warning beforehand, we'll try to get an anesthesiologist down to the emergency room, but many times we're not there. So the initial, if I can anticipate what you may be asking,
Yeah.
the initial airway management
Right.
for patients who have obvious brain injury and will obviously, even not necessarily going to the operating room, but maybe just going for a CT scan. But if they're unconscious or have altered level of consciousness, their Glasgow Coma Scale is decreased into the 8 to 9 to 10 range. It's very common for the emergency room physicians to manage the airway at that time and get those patients intubated and control their ventilation down in the ER.
Do you ever advise them to in an obvious closed head injury? Do you ever advise them to hyperventilate, or you kind of want to be there to determine that?
Correct. Yeah, we typically don't, because monitoring CO2 in the ER and when their patients are being transported for CT scans or maybe even an MRI or something is much more problematic. Sometimes they will start some mannitol, which is a hyperosmotic solution, which can help decrease cerebral edema. They may start mannitol in the ER, but they typically don't do any specific guided therapy towards hyperventilation, because we really want to keep that in a pretty tight control. We typically like our PaCO2 to be between 24 and 28, which requires getting a blood gas, which again, in the rush of getting things done in the ER, they may not have a chance to do that. So it's a much more controlled environment in the operating room, and we typically don't institute actual hyperventilation to a determined level until we're in the OR and can really look at their end-tidal CO2, get a blood gas, see what their PaCO2 is, and control that very carefully. Because if you get much below 25 in your PaCO2, then you start getting such significant cerebral vasoconstriction, you're really impacting cerebral blood flow, and that can be bad.
What is it? You know, I haven't been to a major trauma center like at Irvine, and you're level 1 or 2, correct?
We're level 1, yeah.
Level 1, okay. Well, I guess you get CTs very quickly, right?
Right, exactly. In fact, there's a CT scan literally down in the ER. It's right across the hallway from the entrance to the ER. So they can have a patient in a CT scan in 60 seconds.
Right.
In 90 seconds, they could be in the scanner.
Yeah. Yeah, I was surprised. I was talking to an Argentinian neurosurgeon, and he says they can do a complete body CT very quickly.
Yeah, yeah.
Same at Irvine, I imagine.
Yeah, they've got a scanner there. It's obviously it's ready to go 24/7, and yeah, they got patients in there and very, very quickly.
Great. Well, you know, unless we have a question that was submitted by an Indian neurosurgeon who is in bed now at 4 in the morning. He said, his name is Dr. Rakesh from Bangalore. Can you please tell us about important points of ICU care of post-operative neurosurgical patients?
That's a great question. Typically, as we talked about with the CO2 issue, that's really used for transiently decreasing cerebral blood flow. So once patients get to the ICU, our goal is to maintain normal CO2 levels. I would say almost without exception, patients are kept intubated after a traumatic brain injury and an emergency craniotomy. So they're going back up to the ICU, intubated and ventilated. So we maintain normal CO2s. The neurosurgeons may intermittently use mannitol if there are still elevated ICPs. Almost all of these patients have what's called a bolt, which is an ICP monitor that's placed in the operating room, and we can measure, actually monitor and measure intracranial pressures. So we're looking at those pressures real time. And then I'm saving for the last thing, probably the most important thing for maintaining appropriate ICPs, good cerebral perfusion pressure, and good oxygenation is we keep the patient sedated. And typically they're on a infusion of, we use propofol, which has excellent neuroprotective properties. It helps decrease cerebral metabolic rate. It decreases cerebral metabolic rate. It also decreases cerebral metabolic oxygen requirements. So it does two good things. And if we maintain good cerebral perfusion pressures in the ICU, which sometimes we may need some vasopressors to ensure that, but with vasopressors and fluid resuscitation, we keep the cerebral perfusion pressure up. We keep the head of the bed elevated 20 to 30 degrees, again, to help ensure good venous drainage. We maintain good cerebral perfusions. We keep the patients sedated. They're on a ventilator, so we're ensuring excellent oxygenation of the blood and oxygenation of the brain by well-oxygenated blood. And keeping an eye on the intracranial pressures, we can manipulate those with either transient hyperventilation, the use of mannitol intermittently, and these ICPs monitors also are actually drains, so they can actually drain some CSF if the ICPs get too high and help keep the ICPs at an adequate level. Typically, they set the ICP monitors to drain or not drain at anywhere from 15 to 18 millimeters of mercury. Mm-hmm. And that can be actually set on the special ICP monitor, which I'm sure that neurosurgeon is very familiar with.
You know, as you know, frequently head trauma patients come in, they're very combative. It's hard to start IVs. It's hard to do anything.
Exactly.
Assuming a patient, his pressure is fine, but he's very combative, do you go right away with a propofol, or do you sedate them with Valium or any other kind of sedatives?
No, if a patient's really combative and we're confident they have traumatic brain injury, oftentimes they will be electively intubated and get their airway controlled. So when we talk about sedation, that's almost always in conjunction with definitive control of the airway, meaning intubation. Mm-hmm. So if someone's combative, once we get an IV in, we're going to just get them off anesthetized, get them intubated, get their airway controlled, and then we have much better control of basically the entire situation. We're protecting the airway so the patient has food or fluids in their stomach. We don't have to worry about them vomiting and possibly aspirating. So we've protected the airway. We're ensuring excellent ventilation and ensuring excellent oxygenation. And we're sedating the patient as well, of course.
Does sedation alone decrease intracranial pressure? Do you know?
Well, not without airway control. In fact, actually, it could worsen it, because if you don't have the airway controlled and you sedate a patient, they could then become somnolent, have airway obstruction, and actually start having poor ventilation, which will cause their arterial CO2 to rise, to elevate, which is the worst thing you could do, because then that causes cerebral vasodilation, increased cerebral blood flow, and that could worsen intracranial pressure. So sedating a patient who has potential or possible traumatic brain injury or any kind of intracranial mass for that matter without appropriate airway control is actually can be a bad combination.
Dangerous.
Yeah, so elective management of the airway is one of the major tenets of managing patients with any kind of intracranial pathology, whether it be traumatic or even a tumor or an acute intracranial bleed, hemorrhage from an aneurysm or something like that. Airway control is pretty much a very high priority.
Has anything changed recently? Or is it pretty well been the same as far as anesthesia and neurotrauma? Things have pretty well been the same for a long time, or have you noticed any recent developments, or you think things have basically been the same for the last?
Really the same. I mean, I think back to when I trained. I mean, these are the principles I was trained with. You see my hair, my facial hair here, it's a little gray. So it was a few years ago, and very much the same. I mean, the drugs have changed, definitely. We have drugs now that we didn't have when I was training. But aside from the drugs, the basic principles of neurotrauma management for anesthesia are the same, which is airway control, maintenance of good cerebral perfusion pressures, adequate intravenous access, trying to lower intracranial pressure, and providing good anesthesia and analgesia.
Mm-hmm. Very good. Well, Les, I'd like to thank you for taking time on your day off to educate us on anesthesia and neurotrauma, and we look forward to working with you again.
My pleasure, John. It's been great, and if anyone has questions, they can get them to you and certainly send them along to me. I'll be happy to respond.
Okay, hold on, Les. I'm just going to sign off, and good day, America.